Well, it certainly used to be the case that there were many more options than there are now, and there are several reasons for this. And it's something that, of course, we wish was the case, because as we know, the current strategy we have here in the UK is to not do anything about the levels of virus that are present within our community. So this means that vulnerable people are on a bit of a knife's edge, because if they do get unwell, and of course prevention is always better than cure, then they need these therapies to make sure that they don't go into hospital. Now, when the Living With strategy first came out, we had an array of what we call monoclonal antibodies, which are like having a sort of an instant immune response, if you like, which will bind to the virus particles in your veins and stop it spreading around your body. But we also have these targeted drugs, these small molecule drugs, which target the virus life cycle specifically. Now, one issue that we have now is because the virus evolves so quickly that many of those monoclonal antibodies that we had available now no longer work against these very fast evolving Omicron subvariants that are passing around the world as an incredible rate, really. So we can't use those anymore. We shouldn't get rid of them because they may work again in the future if the virus changes again. And of course, there was one very effective, what we call a prophylactic therapy, which could hang around in your veins for a long time, which unfortunately we didn't approve in the UK in time, called Evusheld, which could have given people long-lasting protection. But hopefully there's another one of those in the pipeline. Now, as well, we have our drugs that we had available which work against the virus, but unfortunately one of those, molnupiravir, doesn't seem to work as well as we thought in terms of protecting people from going into hospital. And that's because it works in a slightly different way to most conventional antivirals. But then we also have remdesivir, which is one that we must have heard of from the beginning of the pandemic, which does work, but unfortunately you have to give it in your veins. So you have to go into hospital to have that. And so what we're left with really is this tablet called Paxlovid, which has a drug that targets the virus, as well as another drug which slows your liver down, breaking drugs down, and allows that drug to be given at a lower dose. And unfortunately, that means that certain clinically vulnerable people on different medicines can't have that drug. So really, because we haven't had more recent trials in the most recent viruses, NICE, which is the body that recommends these drugs for use, have decided that we should just keep the Paxlovid. So we've lost multiple monoclonals. We've lost remdesivir and molnupiravir, although they're arguing against this. We still do have some drugs that help us if we develop a really severe disease where our immune system is going crazy. But in terms of the antivirals that stop us going into hospital, we really don't have many left. And of course, the concern there is that eventually that virus will become resistant to that as well. So what I would favor is that we look again at combining these drugs together as combination therapies, which should help us better in the longer term. And of course, we need to research better antivirals for the future, because this virus is not, unfortunately, going away and vulnerable people remain at risk.